everybody. Thank you very much to invite me again to your Congress of the Association of Obstetric Anesthesiologists in Ukraine. It's for me a pleasure and an honor to be here with you, even online. The topic that we are going to afford today is hemorrhagic shock and coagulation disorders in obstetrics. But I think it will be much more interesting for obstetrics anesthesiologists to focus on postpartum hemorrhage and how to improve the treatment of these women. We are going to try to afford the causes of PPH, the severity of PPH, what is the new concept that is patient blood management, the famous PBM, the coagulopathy and the importance of this coagulopathy with describing the paradigm change, and goal-directed therapy, trying to conclude with some practical recommendations. What do we know at the moment? Because many of the lectures dedicated to postpartum hemorrhage speak about the same things. So we will try to pass quite quickly for this topic what we already know. A brief reminder. It affects 1 to 2% of deliveries. In the definitions, we have a lot of sources of improvement because some definitions are based on the blood volume loss, some other definitions are based on the hemodynamic parameters, and some others of the needs of transfusion. So we need a uniform definition, but in general, after 500 milliliters of blood loss after a vaginal delivery and after 1 liter when we have performed a C-section, we are in front of a PPH. And what we have to do is to try to avoid the progression of a PPH to a severe PPH. There are several risk factors, but one of the most important is the cesarean delivery epidemic that we are suffering in different parts of the world, especially in Europe and in the high-income countries. And not so high-income countries. There's a real epidemic in South America where this percentage may reach up to 90%. It is an important risk factor for the development of placenta accreta spectrum diseases. Maternal mortality and morbidity is important, and there are important differences between low and middle-income countries compared to high-income countries. It is true that in LMIC, maternal morbidity is higher than in high-income countries, but it's decreasing slightly but firmly and continuously because of the improvement of care in these areas, while in high-income countries, the associated pathology and the migrant crisis that we are having nowadays makes that the increase that it has been described, an increase in maternal mortality and morbidity in migrant populations, especially in women who suffer of ethnic discrimination or economical discrimination or something like that. It is also important to focus on the quantification of bleeding and the use of gravimetry as soon as the PPH is declared or even before that. And about the basics, the lethal triad avoidance, that is to avoid coagulopathy, hypothermia, and acidosis, and also hemodilution to try to avoid this coagulopathy related to factors that we can control, and the use of oxytocin systematically in an episode of PPH and in postpartum anyway, systematically as part of the management of the third stage of labor. If we speak about maternal mortality, we have to go to the embrace studies and to the maternal mortality studies that have been published for years and decades in the UK. And in terms of hemorrhage, they have seen that amniotic fluid embolism is one of the most important problems. It does not happen very often, but when it happens, there is a very important and severe coagulopathy, and women who died have had a delayed or inadequate correction of this coagulopathy. Viscoelastic devices can minimize these delays and must be interpreted correctly. That's one of the limitations. But it's not everything related to maternal mortality. There is also maternal morbidity, and in this maternal morbidity, the most important of them is the incidence of cardiac arrest. Cardiac arrest have been studied in the UK in the NAP7 survey, and they have seen that major hemorrhage is the main cause of cardiac arrest. So the management of hypovolemic and bleeding patients even in the UK can be improved slightly. About the causes of postpartum hemorrhage, we have talked about the 4 T's: tone, tissue, trauma, and thrombin, but instead of thrombin, we should speak about coagulopathy, and in the coagulopathy, low fibrinogen, low plasmatic fibrinogen, and increase of fibrinolysis. That's the really important thing of thrombin, not patients that have been anticoagulated, the patients who develop an acquired coagulopathy. We have mentioned before that 1 to 2% of deliveries are affected by PPH. It is decreasing in low middle-income countries and increasing in high-income countries because of increasing maternal age, obesity, multiple gestation, induction of labor, previous cesarean deliveries, and the incidence of acrotism, serious comorbidities, and some unknown factors that are really affecting and increasing the incidence. We know that we have to be prepared in high-risk cases, and we know which are high-risk cases: multiple pregnancies, previous history of PPH, induced hypertension, and many others. But up to 50% of PPH happen in patients who did not have any risk factor. So it's good to be prepared, but we have to be ready for whatever it may happen at any moment. Quantification of bleeding, gravimetry, it's much better to measure, to weight, than to calculate. And let's remember, 1 gram, it's equal to 1 milliliter. So if we have 500 grams and we subtract the dry weight, we know that we have 500 mils of bleeding. So quantify instead of estimate, because PPH is very often overestimated. The systematic use of uterotonics, they have to be used systematically in the 3rd stage of labor: oxytocin, methylergonovin, carbetocin, carbaprost, misoprostol. It may be slightly better carbetocin when compared to oxytocin, but they share and have the same side effects, carbetocin compared to oxytocin, and mainly hypotension. The risk-benefit ratio reflects that all of them are better than placebo, so they have to be used systematically and in the right doses. But when we are called and we notice that it is happening at PPH, we need to know how sick is the patient. Sometimes we arrive late to the scenario, and pregnant patients are usually fit and healthy. And we need to know as objectively as possible if the patient is affected by the bleeding or not. And we have objective tools in our hands as it is shock index. Shock index, it's an easy and cheap parameter that it's not more than heart rate after systolic blood pressure. It has been widely used in other settings like sepsis or trauma. And if this ratio is over 0.9, the mortality increases in the trauma and sepsis settings. And it has been described in obstetrics, the golden hour for postpartum hemorrhage, like in polytraumatic patients, and the rule of ones. If the patient is over 100 beats per minute, shock index over 1, and estimated blood loss over 1 liter, it is a clear and easy identification of severity of PPH and a high risk of coagulopathy. In this review article that we have recently published in the European Journal of Anesthesiology, we have found that we highlight here that if the patient is tachycardic, pale, hypotensive, with critical values of blood gas analysis, especially base excess below 4 and pH below 7.2, with a shock index over 1, lactate over 4, and even more, oliguric and some other parameters, it is quite clear that this patient is at risk and deserves a close and active monitoring. So we have the body temperature that should be maintained at over 34, pH over 7.2, and calcium over 0.9, but not artificially. Active warming is fine, but we don't have to give bicarbonate. We have to keep the patient with a good perfusion, that it's shown with a base excess lower than 6, lactate lower than 4, and arterial venous to central difference of PCO2 less than 6 millimeters of mercury. And fibrinogen levels is important to be over 2 grams per liter while the patient is bleeding. What we have new in this field, the patient blood management. Patient blood management is a patient-centered, systematic, evidence-based approach to improve patient outcomes and managing and preserving patients' own blood while it is being promoted patient safety and empowerment. It decreases the mortality, the rate of infection, the rate of acute myocardial infarction or a stroke, and the length of stay. So it is important to know that patient blood management starts before the labor and delivery. It starts with the pregnant lady in the first pillar of patient blood management. And why do we have to pay attention, especially to pregnant women? Because they have a high prevalence of iron deficiency, because PPH affects millions of women, and it is a leading cause of maternal mortality all over the world. Postpartum anemia affects not only the women, also the neonates, their care, and the families, because there is a gender bias, because a pregnant population is considered a healthy population, and women are also important, and there are differences between the implementation of PPM between high-income countries and low-income countries. In high-income countries, the lack of access to good health and good care to deprived populations, and no awareness of the importance of PVM. and in low and middle income countries, lack of resources, gap of knowledge, and no access at all to healthcare resources. In the patient blood management in pregnancy, in the first pillar, during pregnancy and before delivery, we should screen for iron deficiency and treat according to the trimester we are and the severity of anemia. In the first pillar, we have to focus on anemia, and if the delivery has started yet, tranexamic acid use as early as the hemorrhagic episode starts, the use of oxytocics, and the use of regional anesthesia, whose use is related with a lower blood loss. Which are the risks of anemia? Anemia is not a number, it is also a disease, and there are many maternal risks that are increased and also neonatal risks, including autism and intellectual disability, and many other maternal risks that may include even maternal death, and it may have a physical, psychological, and neurocognitive consequences. But we have to focus also in terms of patient blood management in delivery and postpartum, trying to use transfusion and coagulation algorithms, ideally point-of-care diagnosis or even cell-saver in selected cases, with a rational and restrictive use of allogenic blood products, and in postpartum screening and treatment of iron deficiency anemia and close monitoring for tolerance to anemia. But sometimes we have the PPH declared. And how can we implement the patient blood management principles once the hemorrhagic episode has been declared? It is exactly the second pillar. And in the second pillar, one of the most important things that we have to be aware of is the coagulopathy and severe bleeding appearance. It is a coagulopathy that sometimes it is not related to massive bleeding and that suffers of elevated markers of fibrinolysis, hypofibrinogenemia, and low plasmatic factors 5 and 8. And in these patients, high doses of fibrinogen and antifibrinolytics are required. But how can we diagnose that? We will see in the next few slides. But let's speak now about pro-hemostatic drugs. When we have a PPH, a declared PPH, we have different drugs that we may have to use. Tranexamic, fibrinogen or cryoprecipitate, that it's the main source of fibrinogen, and some others that we will try to analyze. The use of antifibrinolytic drugs is highly recommended by the evidence, and tranexamic acid should be used as soon as possible when the hemorrhagic episode is declared. If we think about prevention with tranexamic, there are no data at the moment to recommend the use of tranexamic before bleeding, even in high-risk cases. What it means that we have to be prepared, but we have to wait until the start of bleeding. What about fibrinogen? There is a physiological hyperfibrinogenemia that has been widely described during pregnancy, and hypofibrinogenemia before delivery is a high risk factor of severe bleeding, as it has been published almost 15 years ago. It is the first factor to be consumed, and the replacement should be ideally based on point of care and viscoelastic tests, and empirically administer it if needed when the PPH is massive. It is not recommended prophylactically when the patient is not actively bleeding, despite she may have a plasmatic fibrinogen below 2, it is not recommended. And it is also important to know that fresh frozen plasma is not a good source of fibrinogen because of dilution. And what about acute obstetric coagulopathy? Sometimes it happens, and it happens much more often in some etiologies, especially amniotic fluid embolism, preeclampsia, placenta creta disorders, and some others. But sometimes it is unexpected, and we need, ideally, point of care for diagnosis because they need a guidance for an aggressive treatment with fibrinogen. The obstetric coagulopathy can rapidly lead to massive and ongoing PPH, and if your fibrinogen is less than 2 grams per liter, the probability of progression of PPH is 100%. Early fibrinogen is the only independent predictive marker. So if we administer fibrinogen, why not to administer it prophylactically? We have mentioned that it's not recommended because they tried in this randomized controlled trial to give fibrinogen prophylactically to women who had lower counts, and they did not find any difference with the use of preventive fibrinogen in patients with normal fibrinogenemia. And the following step should be to perform a randomized controlled trial. Randomized controlled trial when women had started bleeding. But this kind of approaches to the PPH episodes are difficult because we had, or the authors had to get the informed consent when patients had started bleeding, and the inclusion of patients in the two groups were performed when fibrinogen plasmatic levels were over 4 grams. They found anyway something important, that no thromboembolic events or other relevant adverse effects were reported in the fibrinogen group. But there are limited chances to perform more randomized trials in coagulopathic patients in our Western world and in high-income countries. What about point of care in pregnancy and PPH? They are becoming more and more popular in different settings. We can find when we perform a viscoelastic test like ROTEM or TEG or Quantra, hypercoagulability in pregnancy. That's a fact, and we know that it's part of physiological changes of pregnancy. But there is also, and there is a PPH episode, a good correlation between FIB-10 A5 at 5 minutes of the starting of the test and low plasmatic fibrinogen. So FIB-10 has been highlighted as a good predictor of progression of PPH and severity of PPH. XTEM is a good correlation, it has a good correlation with clotting factors deficiency and also the platinum. Despite it is not validated yet in the obstetric patients, it has been validated in cardiac surgery patients. The role of platelets subtracting FIB-10 to XTEM at 10 minutes could give us the idea of the platelet function with ROTEM. Which are the outcomes and recommendations with the use of point of care? It is important that what we are trying to demonstrate and we are seeing nowadays is less transfusion, less use of blood products, less transfusion of volume overload, and less days of stay in ICU. And the tips to use properly and efficiently the point of care, the viscoelastic test, is using them when there is a bleeding over 1 liter, or even better, over 1.5 liters, when there is an hemodynamic instability or active important bleeding. We may repeat every 20-30 minutes or every 0.5 or 1 liter, because the situation may be dynamic and may be changing with the administration of some products. It is useful to roll in or out hypofibrinogenemia in moderate PPH to be sure that we don't have to administer fibrinogen, and it may be repeated when needed. It is not accurate for the detection of thrombocytopenia, and these are the most important recommendations for its good use. But when we have a really massive PPH, it is important to have a protocol, but it is even more important to know how to act, because these situations used to happen at 2 a.m. with nobody or very few people at the hospital, and to have a good blood bank, a good communication, and a massive transfusion protocol that may include a ratio of 4:1 between blood plasma and platelets plus extra fibrinogen could be useful. And don't forget to include first tranexamic acid. It is also highlighted in our paper in the European Journal of Anesthesia that in the very important and massive PPH, we need a massive transfusion protocol, and especially in etiologies like abruption or amniotic fluid embolism, very related to acute obstetric coagulopathy, we should consider the administration of empirical doses of fibrinogen. There have been some studies that have been performed in the UK that highlighted the role of the viscoelastic tests, and especially the FIB-10A5, to predict the severity of hemorrhage and the need for transfusion. And when FIB-10 at 5 minutes is below 10 millimeters, the probability or the association is high with a high blood loss, the probability of transfusion of any red blood cells, and the transfusion of more than 4 units, or the appearance of or the need of invasive procedures to stop the PPH. These studies have started several years ago, and they continued with the OBS-KIMRU, that it's a national project that concluded like as a quality improvement project, that early identification of PPH episodes, a good risk assessment, multidisciplinary approach, and ROTEM-guided therapy are really useful in this kind of patients. And they found in similar studies that the incidence of ICU admission, hysterectomy, and complications were much lower. And what they have seen along the years is a less need of fresh frozen plasma use with the use of these algorithms and this multidisciplinary approach and use of viscoelastic tests, and less women who needed more than 5 red blood cells units. They continue with these studies, and the next objective of this group is to characterize the coagulopathy and the characteristics of the acute obstetric coagulopathy in PPH. The next product that we may have to use is prothrombin complex concentrate. At the moment, it is not recommended for nothing more than acquired factor deficiency or for urgent reversal of warfarin. And there is limited evidence for the use in any other setting. In our national guidelines in Spain, we open the door to some specific scenarios or of refractory coagulopathy, and in this context, we open the door to its possible use. And also, it has been mentioned in other guidelines recently. Calcium is needed for coagulation and also for uterine contraction, and it has been observed and studied in this context. There have not been described big differences in bleeding with calcium administration compared with placebo, but there are promising results according to these studies depending on the cause of PPH. Factor 13 is a coadjuvant of platelets, and it's related to platelet count. And in some commercial formulas of fibrinogen, it has been added to fibrinogen. But usually, at least in our hospitals, it is not easy to measure the plasmatic levels of factor 13, but it may be a biomarker or a predictor of severe PPH. The platelet count is related to factor 13 quantification. So if we have a low platelet count, we may have also a deficiency of factor 13. But according to the results at this moment, there are no conclusive results. There is a change because of the appearance and the description of the acute obstetric coagulopathy in the hemostatic management of postpartum hemorrhage when the acute obstetric coagulopathy appears. We have mentioned before that it is all often related to the massive release of tissue factor, that it's abruption, amniotic fluid embolism, placenta creta spectrum diseases, and some unknown factors. But some other times it is not related with the blood loss and with these etiologies. And it is characterized especially by a very important and severe hypofibrinogenemia that it's an early marker of this acute obstetric coagulopathy and also predicts transfusion requirements. The viscoelastic tests are really a good contributors for the early diagnosis of this coagulopathy, as they allow the early administration of fibrinogen concentrate. In this study, the authors have seen the linear decrease of the factors along the hours of the episode of PPH. They have seen that very few women develop an early acute obstetric coagulopathy, and probably fresh frozen plasma is unnecessary. Meanwhile, tranexamic and fibrinogen early administration is much more useful. And probably in the future, we should know how and when to replace fibrinogen and which is the optimal source of it. In this acute obstetric coagulopathy, there is an increase in the plasmin antiplasmin complexes and a rapid decrease of functional fibrinogen and factor V. These findings strongly support the role of tranexamic acid and early replacement in acute obstetric coagulopathy, and will help to inform future prospective clinical trials and guidelines for looking for an optimal treatment strategy. Let's mention the surgical treatment, as we have suffered a very important socio-demographical change in labor and delivery, and there is an increase in the number of cesarean deliveries all over the world. The need for surgical measures and surgical treatment has increased and changed during the years, developing a lot of treatments related to embolization and interventional radiology. Among the newest treatments, we have to mention the use of Reboa balloon. There have been used the prophylactic placement of internal iliac balloons and some other procedures, but nothing as effective as the Reboa, as it is placed in the area 3 of aorta infrarenally, and when it is inflated, it occludes the entire lumen of the aorta, avoiding and cutting all the blood flow to the inferior part of the body, allowing to perform an hysterectomy without a bleeding surgical field. We have a lot of experience on this, and we have published our experience recently with two hospitals in Israel and two hospitals in Spain. Having the perspective, I think it is the widest paper with the widest series of Reboa, with the perspective of the anesthetic management of these cases. In this setting of PPH, we can also use the cell savers, and at the moment, the evidence of their use is high in terms of safety, not economically, but safety. It looks that they are safe. If we look at the results of the Salvo trial that has been performed in the UK in 26 hospitals, including many patients, it reduced the transfusion rates. There were no amniotic fluid embolism, but they recognized a high cost. It may be an alternative for Jehovah's Witnesses with accretism in scheduled cases where the risk-benefit ratio may be good. There is also another study where they used in the UK, where in a single hospital, where they used the cell saver systematically in every cesarean delivery. They found it could be useful, but in my opinion, it will not be cost effective. The strategy, trying to start putting things together, is to reach basic preconditions to avoid the lethal triad, having a good temperature for the patient, a good pH, and a good plasmatic calcium levels, and consider cell salvage if we are in front of a high-risk case. Early use of antifibrinolytics as soon as the patient starts bleeding. Use blood gas analysis and viscoelastic tests as soon as possible, but laboratory tests, platelets, and traditional coagulation tests are also useful. Initiate transfusion protocols, and the diagnostic is available if you are in front of a massive hemorrhage with fixed ratios 4:1 that may be life-saving in some situations where ROTEM or individualized approach cannot be used. The targets should be an orientation: hemoglobin, platelets, fibrinogen over 2, 15/12, and some other numbers, but we don't transfuse numbers, we transfuse patients. And in cases of refractory bleeding, we may consider factor 7A, despite there is not any new evidence to recommend its use. For taking home messages, the multidisciplinary approach is important to try to prevent, if possible, applying the patient blood management principles, the first pillar, to have clear definitions of what is a PPH episode and quantify the bleeding. Start with basics, avoid hypothermia, acidosis, and dilution. Use protocols for the use of procoagulants when they are needed. Evaluate severity and coagulopathy to try to detect as soon as possible an acute obstetric coagulopathy. Consider RIBOA and radiology, interventional radiology, in the multidisciplinary approach. Monitor with a point of care, but also human monitoring is important. Surveillance of the patients and transfusion. Remember that transfusion may be harmful, but transfusion also may save some lives. Thank you very much, and I'm open to your questions or comments if it's available. Thank you very much.